Powell's asked me to talk about deformity analysis. That presumes that we know what a normal limb looks like, and that opens the question of why legs are shaped the way they are. So why are legs shaped the way they are? Skeletal geometry and limb alignment has a mechanical function. So I wish to cover why are legs shaped the way they are, how do you recognize a limb deformity, and a few cases, simple cases of deformity correction. Powell's may be considered the father of modern biomechanics of limb alignment, and Powell tells us that limbs are designed the way they are to transfer the body weight or body mass to the ground while minimizing biologic stress. And this article from JBJS, the British Journal in 1992, should be read by every orthopedic surgeon. Powell's put out this challenge. That's to design a limb while minimizing the forces and transmitting the weight of the body to the ground. And he starts suggesting with a 10 kilogram weight sitting on top of a 5 square centimeter, and that equals 10 kilograms per centimeter squared. So over here on the right side, we see a graphic recording of 50 kilograms on top of a column. And this little, it's a symbol of the relative force that's present throughout his diagram. So this is the first diagram. So the steps to design a human limb, the first thing we'll do is we'll have 10 kilograms on top of a column. But if we have two columns, which is the same as standing on two legs, then the load in the column is cut in half so it's 5 kilograms per centimeter square. But if we stand on one limb, the mass is cantilevered off to the side, which puts a tremendous bending stress in the column itself, and the average load jumps to 228 kilograms per centimeter squared. Now, the joint pressure, if we add a hip joint, we actually move the femur more lateral to the side, which increases the load in the column, and the load through the column jumps to 350 kilograms. We throw in a knee joint, and in order to keep the limb column from collapsing, we need a very strong lateral tension band, the equivalent of the lateral collateral ligament. But the load is shifted across the knee joint itself, so it drops to 70 kilograms, 77 kilograms across the knee joint itself. We need a tension band at the hip joint to keep it from collapsing. And the load in proximal femoral neck becomes less as you approach the center of the femoral head. But the next thing to reduce the forces at the knee joint itself is we need to expand the surface area. And here we've expanded the surface area. That changes the tension, which is in the lateral collateral ligament, but it increases the surface area, decreases the pressure, and now the load at the joint surface itself drops to 10 kilograms per centimeter squared. Next, we'll throw in tension bands on the outside of the femur to reduce the bending moment, and on the outside of the tibia to reduce the bending moment. When we do that, we see that the load in the femoral column has dropped to 230 from some 350, and the load in the tibia has dropped still to about 297 or almost 300 kilometers squared. But the fact that the tension band is on the lateral side of the tibia is the explanation for why the muscle is on the lateral side of the tibia and there is no muscle on the medial side of the tibia. So the next thing to reduce the forces in the column is to move the foot towards the midline. So we tilt the entire column off the vertical. This moves the knee joint closer to being underneath the center of mass. That reduces, by the ankle joint, load in the column to a quite small degree, and it drops the load at the knee joint surface to about 7 kilograms. And then we do one further addition. We take the knee joint and we just leave the foot in its position, leave the hip in a position, but we push the knee joint closer to lie underneath the center of mass of the body. And that creates an angle between the femur and the tibia, the so-called tibial-femoral angle. So that's there in order to get the knee joint underneath the center of mass. And that drops down the load across the joint itself to 5 kilograms per centimeter squared. And this is the overall design of how we take a column and reduce pressures to biologically limited amounts. Now, a horse cannot stand on one leg, and the tibiofemoral angle in a horse is 0 degrees because it always is standing on 2 legs. Man can stand on one leg, and we can balance on one leg, and balance on one leg is necessary for bipedal gait. And this is made possible by moving the knee joint medially so it's closer to the center of mass, and that's why we have, as I just said, a tibiofemoral angle. So normal alignment, the mechanical axis, which runs from the center of the femoral head to the center of the ankle, and it runs through the knee joint near its center. The mechanical axis is tilted approximately 3 degrees from the vertical, and at the same time, the joint line is horizontal. Therefore, the angle between the femoral head and the joint line on the distal femur is 93 degrees on the medial side, and the angle between the tibial shaft and the medial knee joints 87 degrees. So we have this single mechanical axis that's tilted 3 degrees, the joint line being horizontal, which gives us on the medial side 93 degrees, on the femoral side 87 degrees on the tibial side, or on the opposite side, the lateral side of the femur 87 and lateral side of the tibia 93. And that's all you need to remember to begin to analyze the deformities. Now, Pauwels worked in Aachen, Germany, and Paul McKay worked in Liège, Belgium, which is only about 20 miles apart. And McKay expanded on Pauwels' theories in order to treat knee arthrosis with realignment of the limb. And as a young surgeon, he used to review his cases, and he told us he got on the train Friday afternoon and took all of his cases up the road to see Pauwels, and Pauwels went through the cases and analyzed them, and he subsequently wrote this book, Biomechanics of the Knee, and it's a masterpiece for anyone who wants to understand limb alignment. And McKay states that the total force, which he refers to as R, crossing the knee joint is the sum of the body weight, which he referred to as P, French for weight, and the muscle force is L. So the mechanical axis, A, in this diagram of McKay, approximates the location of his A. Now, P is the true body weight, L is the lateral vector, and A is the mechanical axis. So the mechanical axis then, and the resultant force vectors are the sum of the weight and the muscle force acting across the knee, and that goes roughly through the center of the knee, actually just to the medial side. So if we change the weight or we change the lateral muscle vectors, then we get a change in the location. The resultant vector crosses the joint. So normally it crosses near the medial tibial spine. If we add weight or we take away muscle, the resultant vector will shift towards the medial compartment, and we'll begin to get a medial compartment overload. So R will shift medially if we have varus, such as a varus malunion, or a congenital varus, or the varus can be either in the femur or the tibia, or if we get laxity in the lateral collateral ligament, or if we get laxity in the anterior cruciate ligament, or if we lose articular cartilage from the medial compartment, or if we transfer the tibial tuberosity medially, or if we have muscle atrophy or sarcopenia. So with age, we develop sarcopenia, which is muscle loss, and that'll shift the resultant vector medially. And if the weight goes up, which commonly occurs with age, probably as a result of taking in the same number of calories with less muscle, then the weight P will increase and the resultant vector shifts medially. And that's the explanation for the common occurrence of medial compartment arthrosis with age. Now, if R is moved, then the surface area, which is accepting the load, is changed. So an increase in joint load leads to arthritis. That takes us back to normal alignment. Normal alignment allows the weight transfer to go to the ground within biological pressure tolerance limits. So the resultant vector is the sum of muscle and weight. So the basis for deformity analysis and for realignment is this. The mechanical axis is tilted 3 degrees. Medial side of the femur at the knee joint is 93 degrees relative to the horizontal, and on the tibial side, 87 degrees relative to the horizontal. If the mechanical axis does not cross the knee joint near the medial tibial spine, there is a deformity in the limb. So how do we go about locating that deformity? Well, we have to break it down into 4 simple questions. We say, where is the mechanical axis? Is it varus or valgus? What's the total deformity? And where is the deformity located? Femur, joint, or tibia? So here we have a limb, and we might look at it and say it's varus. However, if we drop a mechanical axis from hip joint center to ankle joint center, we see indeed this mechanical axis is not near the medial tibial spine, it's well into the medial compartment. So we have a question, is it varus valgus? Well, since the mechanical axis is in the medial compartment, it's varus. So what's the total deformity? Well, now we'll drop a straight line from the center of the femoral head through the center of the knee joint, and a separate line from the center of the talus to the center of the knee joint. And the deviation of that line, deformity in the limb. This limb has a 14-degree deformity. So our next question is, where is the 14-degree deformity coming from? Well, again, just remember this diagram here with the mechanical axis tilted 3 degrees, leaving the medial femur at 93 degrees to the horizontal and the medial tibia at 87 degrees to the horizontal. In this particular case, we draw a straight line from the center of the femoral head to the center of the knee joint, and then we look at the horizontal, or the joint line, actually, the joint line. And on the medial side, this angle measures 86 degrees. 93 degrees should be normal. So the difference between 93 degrees and 86 degrees is 6 degrees. So there is 6-degree varus deformity in this femur. Now we look at the knee joint. The joint itself, we draw a tangent across the bony end of the femur and a tangent across the proximal side of the tibial, across the tibial plateaus. We start off in life with that line being exactly parallel, and with weight or with wear of the medial cartilage, we may get some tilt. In this particular joint, the tilt is 4 degrees. That gives us then 4 degrees of deformity in the joint. Nextly, we look at the tibia. Well, if we draw a line from the center of the talus to the center of the joint and look at the line across the top of the talus, this knee measures 83 degrees on the medial side. It should be 87 degrees, so we have a 4-degree difference. So in this femur, the deformity exists 6 degrees in the femur, 4 degrees at the joint, and 4 degrees at the tibia, for a total of 14 degrees. So we've taken a femur in which we've taken a limb, in which we see a potential deformity of 14 degrees varus, and find out that it's located 6 degrees on the femoral side, 4 degrees on the joint, and 4 degrees on the tibial side. Looking at some simple cases. Here's a 76-year-old male. He has a dislocated patella. He's 3 months after having a revision total knee. And here's his x-rays. It appears to be a well-fixed prosthesis. We can see the patella located on the x-ray, and we can see the AP radiograph.
All right, go out.
Here's the patient.
Push it back. And go out. And again. Up.
This patella is chronically dislocated, and so his knee is completely unstable, and he dislocates with every step. He basically can't walk. So we say, is there an alignment deformity possible in this case? Well, if we look at it, we have a suggestion valgus might be present. So we obtain the whole leg standing radiograph with the patella pointing forward, the knee joint axis in the plane of the film. And he clearly has a valgus deformity. We drop a mechanical axis down the limb, and it's on the lateral side of the knee. And the deformity measures 15 degrees. That's the total deformity. So what do we do at this point? Another revision total knee 3 months after the last revision, or any other choices? Well, first let's analyze and try and figure out where the 15 deformity exists. It could be at 3 sites. It could be the femur, it could be the joint, or it could be the tibia. So we make the measurements on the medial side of the femur across the joint line. We measure 102 degrees. It should be 93 degrees. That tells us there's a 9-degree valgus deformity at the femur. The joint surfaces are exactly parallel, so there's no deformity in the joint. It's 0 or no deformity. And on the tibial side, we see that the medial tibia is sloped at 93 degrees, and we said it should be 87 degrees. So that's a 6-degree deformity on the tibia. So the total deformity is 15 degrees. We have 9 in the femur, 0 at the joint, and 6 in the tibia for a 15-degree deformity. Well, we might be able to correct this with a 9-degree femoral osteotomy and a 6-degree tibial osteotomy. And because of his age in his 70s, we would do that as a closed osteotomy so that it has more rapid healing. And here he is post-operatively. He's had a closing wedge of the distal femur and a closing wedge of the proximal tibia. 11 months out, the mechanical axis would be at approximately tibial spine would be. We look at the axial view of the patella, and it's well centered. We look at the lateral view, and he is extremely happy. He tolerates a slight bit of shortness, but he's able to do all the things he could not do before surgery, which include walking on the beach, walking up 4 flights to his condo in Mexico, and riding a bicycle. And he's completely stable with good quadriceps strength. How much is actually correctable? Well, here is a patient that I've known for many years. She is in this photograph 92 or 2 years of age. Until she was 88, she skied all winter when the right knee became too painful. In 1987, when she was 61 years of age, I saw her for pain in the left knee, and she underwent a left distal femoral osteotomy for a valgus deformity. Now here's her valgus deformity in 1987 on the left side. You can see really an advanced arthritic destruction. She had a medial closing wedge osteotomy. In 22 years, for 22 years, she did all activities, including skiing, with no pain or discomfort. After 22 years, when she was, I think, 87, I did a lateral urine compartment arthroplasty, which she was happy with. Here's an 84-year-old who is a number of friends that are not happy with total knees, so he would like something done, but he will not have a knee arthroplasty, period. So we look at his deformity, and I measured the deformity at 24 degrees and put a closing wedge distally, not to remove quite. Here he is standing, post-op, healed, 2 weeks post-op, not healed all the way. But he's amazingly, for some reason, developed the appearance of a joint space immediately, and he was extremely satisfied after that procedure. Here's a 65-year-old who just recently quit playing tennis. He'd played every day. Obviously, this degree of arthrosis has been there for some time, but it finally reached the level he could no longer tolerate it. I measured a 16-degree deformity. We can see on the film on the left side, there's a lucency here, which is suggestive of a so-called osteonecrosis. We can see the defect present on the film 3 weeks post-op after a lateral closing wedge tibial osteotomy. 4 years later, he has a joint space. He's playing tennis every day on a regular basis, and that defect apparently has reconstituted itself because it's no longer visible. Here's a 41-year-old. He's 50 at this age, but at 41, he was seen for after polytrauma. Both knees were involved. This knee, he was told he was too young for an arthroplasty. But the pain was predominantly on the medial side. He had an 8-degree deformity. So we did an osteotomy. Here he is, post-osteotomy, lateral closing wedge in this case. And at 9 years, he said he's better than he was before the osteotomy. He's not ready or needing a joint replacement and has no real complaints, and he works all day. Here's an interesting case. An 18-year-old high school student who was first seen in 2002. And he had a chief complaint of pain and problems in both knees since he was 12 years old. No history of injury. He can't move side to side. He thinks the bone slip. He can't push off in basketball. He doesn't think there's anything in the joint, but there's some slipping, there's some stiffness, there's swelling, there's insecurity, there's pain going up and down stairs and up and down hill, and the knee gives way. And he can do golf, but nothing else at this point. He's 18 years old in high school. On examination, he's normally except there appears to be valgus. He can squat with no complaint. His motion shows a little restriction to extension. He has an effusion. He's got audible crepitation with active extension of the left knee and a 4+ positive J sign. No apprehension with trying to displace or dislocate the patella. It clinically appears to be Alta. There's some atrophy in his thigh. He's got no varus valgus instability, no anterior-posterior instability. He shows probably an increase in hip internal rotation at 7 degrees in the prone position, and an external rotation of 60 degrees. His foot-thigh axis is -10, and he has a tightness of the Achilles. Well, if we look at him, first of all, look at the alignment. His standing alignment film indeed shows that he's in valgus. The mechanical axis is well into the lateral compartment. Looking at his plane radiograph, we can see a crossing sign at the trochlea. The patella is in a high or elevated or alta position. There is a small supratrochlear spur, and there's a double contour on the x-ray, and there's a shadow which could be consistent with an osteochondritis dissecans. So we make the diagnosis of a de jure type 4 trochlear dysplasia. Axial view of the patella on the radiograph shows a rather flat trochlea, even with the knee flexed. And a flexion weight-bearing film shows good joint space, but flattening of the lateral femoral condyle. CT arthrogram, which we used in 2002 to see articular cartilage, shows the patella is perched up on a small articular surface with a large drop-off or cliff on the medial side. And he has reasonable articular cartilage on the patella and on the trochlea. His CT scan, plain CT, shows that all the load is laterally over the lateral facet, and you can see the increased density laterally in contrast to medially, because that's the loads where the load's being carried. So we have a patient then who's 18 years old. He has valgus, he has patella alta, he has trochlear dysplasia, he has osteochondritis dissecans of the lateral femoral condyle and the lateral subluxation of the patella. What possibly could we do for him? There are many options, more than 8. We could leave him alone. We could do a varus osteotomy of the femur, either medial opening or lateral closing wedge. We could do a varus osteotomy of the tibia, either medial closing or lateral open wedge. We could distalize tibial tubercle. We could do a trochleoplasty. We could do an MPFL reconstruction. We could do an allograft of any kind, or rotational osteotomy. Well, the first thing I think that always needs to be considered is the coronal plane alignment. So we did a preoperative plan of a lateral opening wedge osteotomy, fixing it with a 95-degree condylar blade plate. Here he is in the operating room at surgery. This is an image view, and we use a Bovie cord to get a rough idea of the alignment, which seems to be near the medial tibial spine. Here he is 1 year post-op. Mechanical axis is at the medial tibial spine. 8 months after surgery, he came back. He said, "It's outstanding. I can run. There's no pain, no limitations, stairs, no swelling, no instability, nothing slipping. But the other side has a similar problem. I'd like to have it operated on so I can get back to college in the fall." And so he had a contralateral procedure on the side. I didn't see him again then until 14 years later when he appeared. 14 years later, in January 2016, he says, "I've had no problems and no limitation for the past 14 years. I can run and play sports without limitation." New Year's Day, I woke up with a locked knee. That happened in the other knee 14 years ago, and I just needed a piece removed. So he had arthroscopy with this osteochondral fragment from his OCD, which was removed. And here he is in the extension film after 14 years. Here he is in the flexion film after 14 years, but he has no complaint. There is no possible double-blind randomized study which could put all these variables together to decide which of the various treatment options may have been best for him. However, this gives evidence that axial alignment is important. Now, here are the radiographs of a 68-year-old woman who came to me in a wheelchair asking about a total knee. The arthroplasty surgeon had said she has a deformity he didn't think could fix. She obviously has low patellar, patella infra. The patella is in contact with the tibia. She's had surgery perhaps as adolescent. She was young. She has advanced lateral compartment arthritis. There's a clear deformity of the proximal tibia into valgus. She's also had a tibial shaft fracture at some time in the past, fixed with a plate. But if we look at the knee straight ahead, we're looking at almost a lateral radiograph of the foot, which suggests she has rotational deformity as well, and she clearly has severe valgus. So in preparation for a total knee, we tried to do the simplest thing. But going over the diagnosis, she clearly has a malunion and external rotation of the right tibia. She has intrafemoral inversion of both the right and left limbs. She has increased external tibia, both the right and left side. She has recurrent dislocation of the left patella. She's got a right patella baja. She's got a valgus growth disturbance of the right tibia. She's got a congenital valgus of the left tibia. She's got lateral compartment osteoarthritis on the right, a lateral joint convergence on the right. We could do osteotomies of the femur. We could lengthen our patellar tendon. We could do an osteotomy of the tibia, either varus or rotation or proximal middle distal. On the axial X-ray, the patella is not seen. It's down distally around the corner, contrasted with the left side, where we can see a trochlear dysplasia. Her femoral anteversion is quite high bilaterally, 39 and 37. Her tibial torsion is 36 and 54, so indicating it's a 20-degree external rotation tibial deformity. So the simplest thing to prepare her for a total joint would be a single osteotomy at the level of her proximal deformity, fixed with a plate, and a proximal transfer of the tibial tuberosity, because the MRI showed her patellar tendon is intact. Here she is after surgery, mechanical access basically through the center of the joint. Axial view of the patella shows it's centered. The lateral X-ray suggests maybe a little recurvatum. But at 2 years post-op, she's walking and she says, I don't need a total knee. This knee is better than the other side, which still has a recurrent patellar dislocation. So the conclusion of this is limb alignment is very important. The limb is shaped for a reason, a certain reason, and we look for it to have a lack of shape in the femur or the tibia. If that can be corrected, is the first step in deformity analysis and correction. And thank you very much for listening. Limb alignment,
that was
biomechanics. A good osteotomy is very good.